Hello, everyone. I hope you guys are having a great start to your week. Wanted to hop on and do just a quick sort of lecture, I guess, or a quick conversation about the topic of content this week, which is suicide risk assessment and intervention. First part of a couple weeks of content that you guys are going to go through. So first of all, working as a clinician for, many, many moons at this point, I've had my fair share of interactions with suicidal ideation related to clients. I've had my fair share of interaction related to attempts, successful attempts from clients as well. And really anything and everything in between, meaning, active plans to histrionic behavior where, they didn't have any intentions on harming themselves. So I'm going to tell you kind of the sky's falling situations that I have had, and then even talk to you about clients that I have on my current caseload that are just kind of battling with things related to suicidal ideation and thoughts. So my kind of sky's falling situation was when I was the director of a large outpatient mental health facility. And there was a client who was really just struggling with just layer upon layer upon layer of difficult situations in her world, and a significant inability to manage those thoughts and feelings. So this particular client was in her 20s. She had been through 15, 20 therapists by the time she came to our agency. I had originally interacted with her, got her to a point where we were making some pretty decent progress, and then transferred her to another therapist. She was with that therapist, and this was all part of the plan. When she was chronic, I was seeing her, I was treating her. When she was more stable, then it was indicated for her to move on to somebody else. So she did really well with this particular therapist for a long time. So for all intents and purposes, this was a win. So what had ended up happening was we saw that her behavior was spiraling, and her inability to cope with the behaviors was getting pretty intense. So she came to the office one afternoon for her regular outpatient appointment, and just, for layman's terms, just lost it. And her therapist, so I could actually hear her, through the walls that things weren't well. So her therapist was trying to de-escalate. The client had opened the door, and by then I was actually out there, because I knew something was up. So this client proceeded to go to this big conference room that we had. And she was just, at this point, she was destroying the contents in the conference room, including pictures that were on the wall. So she was smashing the glass and the pictures on the wall, and she happened to take a pretty large shard of glass. Now, mind you, the police were already called by then, and she held it up to her neck. So at that point, I was kind of all hands on deck. We were trained to de-escalate, situations. So was doing what we do as therapists. And she proceeded to actually harm herself, right? So she had taken the glass and had started to cut her neck. And in that situation, it was pretty dire. It was not, something that she was going to try to do a superficial cut. So one of the things that we're trained as therapists is not to put hands on our clients, of course, unless we absolutely have to. So once I realized that she was, there was no going back from what she was going to do, then I went in and intervened physically, which was not ideal, but in that situation, it had escalated so quickly. I shouldn't even say it was pretty quickly, so quickly and so much that hands-on interventions were the only way that we're going to save her life at that point. Have I also had a client successfully, remove himself from this earth? Absolutely. That is something that is just absolutely devastating. And, and one of those things that will kind of forever be with you as a therapist. We are human, and we do kind of the shoulda, woulda, couldas. I had just seen this particular client the day before for session, and he did not seem out of the norm. There were a lot of complicated measures to where he got access that shouldn't have been in place. There were a lot of complications to the fact that he had access to things, that he was successful leaving this world. So again, kind of two extreme situations in my 20 years of being a therapist. So what I would love for you guys to focus on over these next couple weeks, because you guys are in practicum, use this opportunity to talk to your peers in practicum, your supervisors, when you're meeting for that weekly supervision. Please add the topic of suicidal ideation and how they handle clients to your meetings. I like the fact that the idea of eclectic therapeutic interventions as well as suicidal ideation was the topic of conversation for this week, because I think it's really important that we don't have a one-step approach to how we're broaching this subject with our clients. Let me give you two examples of clients that I have seen recently in private practice. Okay. So first client that came to mind when I was preparing this conversation is a 67-year-old Caucasian male with no history actually of depression, anxiety, no history. He's reporting no history related to symptoms related to mental illness. So he had to have open heart surgery about 6 months ago. And since then, he has not been able to work. His wife, he's the caregiver for his wife, and she is on disability. She has an extensive history of mental illness. And he's also the caregiver to his teenage daughter. And I say teenage because she's getting ready to graduate from high school. So what has happened is we have removed him from the situation where he led a very healthy lifestyle. He was out running almost every single day. He was lifting weights. So we've removed him from that situation because, of course, the open heart surgery. We have also removed him from his employment because, again, related to the surgery, he's not been able to go back to work. And then, of course, all of the ramifications that come with that, right? Related to finances, related to grief, related to sense of belonging, ideas related to his culture, being the breadwinner. He's always worked since he was 13. So he, on his assessment, with his intake, he identified that he had some suicidal ideation. So in this, one-on-one session where I'm just meeting an intake, per se, it's really important for me to address the fact that this person has answered these questions on the scale and had said that they had felt like hurting themselves within the last 30 days. So my conversation with him tends to be it was very organic. I was, again, knowing this information, I was, listening to everything that he had said that had happened to him over the last several months, and just being really empathetic. But then also, as I'm listening to him, I'm looking for things that keep people earthside, like sense of belonging. Are there any spiritual or religious beliefs? Do we have any pets? If he weren't on this earth, what would happen to his family? So I'm kind of, all of these things that we know, like I said, keep people earthside. As I'm listening to his story, I'm just kind of mentally storing this. Okay. So then we get to the conversation where I'm asking him about sleeping. And he says to me, Megan, I really wish some days that I could just go to sleep and not wake up. Okay. So first of all, kudos, I'm praising him for keeping it real and for feeling comfortable enough in stating his honest opinions. And then I'm also saying to him, so tell me more about that. As I'm going, oh my goodness, I totally understand. I couldn't imagine how you feel. You've had so many life changes, that has to be exhausting. Tell me more about this. So thankfully, again, he felt open enough to be able to say, I'm okay. I just am really tired. So then that prompted me to have an even more in-depth conversation about suicidal ideation. Yes, are you guys trained to talk about mandated reporting and HIPAA and all that stuff in the very beginning? But sometimes in that first 5 minutes of your conversation with your clients, you're not talking about that, because sometimes the first thing they do is they get in the session and they say to you guys, I'm losing my mind. And it's so important that you meet them where they are when they're saying that stuff, instead of saying, okay, hang on, let me go through my little spiel, right? So in this situation, it ended up working out well. I would have had to address it eventually anyway, because I knew that he had said that he had some suicidal ideation, but we were probably 45 minutes into the hour session when I was able to say to him, okay, so I know this is the first time that you've been in therapy. Let me actually just kind of backtrack a little bit and tell you a little bit about how I deal with conversations that can feel tough. I'll often say that can feel. So then I was able to go back to him and say, okay, so, for example, I'm a mandated reporter. I said, I don't know if you've heard that before, but what that means is that, what I appreciate that my clients do is I appreciate when my clients are transparent and are forthcoming about those heavy thoughts and feelings. If it gets to the point where you're feeling like you want to hurt yourself, or you're feeling like like you were saying, I don't want to wake up in the morning. And if it's a situation where you have a plan, if you say, hey Megan, I don't want to wake up in the morning, and I'm going to not wake up by doing X, Y, and Z, then I say, then I said to him, then it's my job to help you. Like, it's my job to make sure that you're safe, and that everyone around you is safe. Now, and I also say, I don't do anything behind my clients' backs that I wouldn't want done to me. So, if there were a situation where I felt like I needed to help you, you're going to know about it all along the way. I'm going to say to you, look, I think we need to get some help. Look, I know that you're not feeling really well. What do we need to do? Do we need to go to the hospital? Who's with you? And again, this is in a telehealth setting, when I've been, most recently engaging. So it's really important, as you hear more clinicians talk to clients about suicidal ideation, that you guys develop your own style. Now, that my style is very different with that gentleman than it is with the 16-year-old, that I saw a month ago. Let's, just kind of continue this dialogue. Hopefully this conversation was a little bit helpful for you guys, and reach out to your supervisors, reach out to each other, talk about ways that you can learn to be comfortable with these heavy conversations.